Hello, my topic is viral hepatitis. 30-year-old black homosexual man presented to the local clinic complaining of anorexia, nausea, vomiting, and malaise. He noted the onset of anorexia and nausea a week prior to presentation, but attributed it to the flu. However, intractable symptoms developed such that he had not kept anything down for the past 2 or 3 days and had lost 10 pounds. His past medical history was pertinent for multiple sex partners. His sexual practices included unprotected anal intercourse and anal oral sex. He had a history of adequately treated syphilis and the usual childhood diseases. There was no history of intravenous drug use. He admitted to drinking alcohol. The physical exam revealed a thin man who looked ill. His blood pressure was 110/80 lying down, which decreased to 90/60 upon sitting. His pulse changed from 84 lying down to 108 when sitting. His temperature was 37.5 degrees Celsius, and his respiratory rate was 20. His eyes were yellow. There was mild right upper quadrant abdominal tenderness. His liver percussed to 3 centimeters below the costal margin with a total span of 13 millimeters. No spleen was palpated. Cardiac, respiratory, and other parts of the exam were normal. His lab results included a regular hematocrit, 48%, white count, 6,000 units per liter, pro time, 13 seconds, electrolytes normal, creatinine 1.2, the aspartate aminotransferase, also known as AST, was 1240. The ALT, the alanine aminotransferase, was 1650. The ALP, the alkaline phosphatase, was 198. Total bilirubin was 12.0. The bilirubin was 8. The anti-HAV was a total positive, IgM fraction negative. The HBsAg, which is the hepatitis B surface antigen, was positive. The hepatitis B was total positive, IgM fraction positive, and the antigen for hepatitis C was negative. The anti-Delta virus was sent out to the lab, and the anti-HIV was negative. The urine was pH 7.2, golden brown, trace protein. Glucose was negative, positive for bilirubin. He was admitted to the hospital for volume repletion and antiemetics. After the patient was stable, he was discharged home with warnings that his sexual partners might be at risk for a similar infection and should be seen by a physician. When seen at the clinic 3 months after discharge, the patient was much better. His liver enzymes had normalized. The anti-Delta virus antibody titer had returned from the reference lab, and it was negative. The articles that I worked with were, the first one was about titled Increasing Hepatitis B Vaccination Among Young African American Men Who Have Sex with Men, Simple Answers and Difficult Solutions. The next one was Hepatitis B Infection, Immunity and Susceptibility Among Men Who Have Sex with Men in Los Angeles County. And the other one was Initial Load of Hepatitis B Virus, Its Changing Profile and Pre-Core Promoter Mutations Correlate with the Severity and Outcome of Acute Hep B Infection. As per Sanoko, Abe, Sato, Endo, Takawa, Suzuki, Okamoto in the Journal of Gastroenterology 2007, this man presented with the exact symptoms of hepatitis. The early symptoms of fever, anorexia, malaise, nausea, and vomiting, jaundice, and the right hypochondrial discomfort. The gentleman obviously thought he had flu-like symptoms because these are classic of most viral infections. They come on for a couple of weeks. People think it's the flu and they think nothing of it. But he didn't recover. He also ended up with jaundice, which would be indicative of the elevated bilirubin. The bilirubin was at 12.0, and that is a breakdown of heme, which is processed in the liver. It's typically less than 1.2, hence the jaundice. What they also found in their studies is that a rapid decrease in viral load in the early phase of acute hepatitis B infection was associated with the severity of the disease. Patients with higher HBV load on admission had a higher mortality rate. The HBV DNA level tended to decrease rapidly as the disease progressed. And this case study did explain that this gentleman had positive HBC anti-H hepatitis IgM fraction on admission, and 3 months later his results decreased. Also, in the study by Patasi, Herringer, and Yi in 2002, in the Journal of AIDS and Patient Care, Patasi, Bingham, Say, Smith, and Teshal studied in the hepatitis B virus among men having sex with men in Los Angeles, and Rhodes, Herringer, and Yi in 2002 in AIDS and Patient Care. They both studied men having sex with men and the effects of immunizations. In the 2002 article, these researchers went to bars in Tennessee, gay bars that were predominantly frequented by African American men, and they handed out questionnaires, and they paid the subjects $10, and it was informed consent, and they asked about their sexual history and previous infection history. What they found was that recent studies examining hepatitis B virus by race shows a substantial increased incidence of new HBV infections. This was in 2002 among African Americans, was at a higher prevalence. They also found low rates of vaccination among men having sex with men, and increased incidence and prevalence among African Americans. They said little is known about HBV vaccination acceptance that could help guide tailored interventions, so their goal is to understand the vaccination behavior among subgroups to effectively tailor appropriate interventions designed to implement and treat. Their mean age was 26 plus or minus 6.5 years, and the range was between 18 and 50. They found that the subjects between 18 and 30 had a higher incident rate of being vaccinated. The older subjects were not vaccinated. And the article by Patasi, Bingham, Say, Smith, and Teshal would make that clear, because they explained that in 1982, the Advisory Committee on Immunization Practices recommended the first U.S. licensed hepatitis B vaccine for adults with high-risk behaviors for hepatitis B transmission, such as men having sex with men, be implemented. And then in 1991, they recommended that the hepatitis B vaccine be extended to all infants. In 1997, that extension went to children and infants 18 years of age and younger. And in 2006, that extended to all healthcare workers. So this would explain why the older generation of men having sex with men are less likely to be vaccinated with the hepatitis B, because that initiative started after their infancy. They also found that Rhodes, Herringer, and Yi found 12 traits that led to being vaccinated among this population. A few of those traits are younger in age, which we just discussed, higher educational attainment, and homosexual as opposed to bisexual men. Unfortunately, it tends to be a thought among that population that if you're bisexual, you're not considered homosexual. So they don't get the access to all of the knowledge of STD education and protection and immunizations as in the the regular homosexual community. So because they don't get that opportunity, they miss out on such things as immunizations. This is a growing problem because Patazzi et al. Noted that while men having sex with men represent 2% of the adult population in 2005, nearly a quarter of all new hepatitis infections were adults. In adults, were men having sex with men. Also, this young man, the 30-year-old, his hepatitis A was positive with the IgM fraction that was negative, which shows that he had been exposed to hepatitis in the past, either by vaccine or previous infection without treatment. So the fact that he has a history of hepatitis, possibly A, and the history of syphilis leaves him open to more sexually transmitted diseases because of lower immunity. Fortunately, he's not HIV positive. So he would need to notify his sex partner so they can be tested, and if they're not tested, if they are tested and negative, so they can get immunized. In the Rhodes et al. Article from AIDS and Patient Care, they encourage practitioners to have an open dialogue with their clients and to remove the stigma of men having sex with men, and so people can be more open and more education can be put out so people can become vaccinated. They also encouraged vaccination opportunities in unconventional areas such as such venues as bars, bathhouses, circuit parties, coffee shops, gyms, house parties. And I said house parties are very important because it's an area that does not get much attention. And house parties would make a big difference because this is where you'll probably get more of the bisexual men. They feel more secure to be open in these areas, and if you have a healthcare professional that is there and is willing to offer education and maybe host vaccinations, you could reach a greater population.